Hi, everyone. Thank you for joining us today, both in person and if you're joining us via the recording on our homepage or YouTube channel. Today's October 25 Hudson Valley Nursing Home update. We're going to focus on a couple of things. It's a jam-packed um, program, actually, as I was looking through it this morning. The first part will be a data update with some background on minimum staffing requirements and looking at what's going on with the Hudson Valley nursing homes in respect to their staffing. And then the second part, which will focus on residents' rights, will this month, excuse me, we're going to focus on families and family councils. We're doing something a little bit different because I wanted to provide some background on the staffing issue. So usually we try to divide it up between, one half data part and one half the residents' rights part. And this will be more of a more integrated of some of the residents' rights into the data portion as well. If you have any questions, since we're a small group here in person, please feel free to just let me know. I'm happy to answer them. I think you're all familiar with our organization, but we're a nonprofit organization entirely dedicated to improving care and quality of life for individuals in nursing homes and assisted living. We also do some other work regarding dementia care. We just came out with a dementia care in the community toolkit, which is useful for people living in assisted living or people getting care at home. Very excited about that. We mostly do policy analysis and systems advocacy. We do a lot of work with data, some of which I'll be sharing with you today. And we are, of course, the proud home of two local long-term care ombudsman programs in the Hudson Valley, Region 4 and Region 5. Really appreciate having them and appreciate, as I think you all know, the work that the ombudsmen do for residents. Our website is nursinghome411.org. Everything on the website is free to use and share. If you're not already getting our, I think they're now monthly Hudson Valley newsletters, they're very short. They have some highlights of recent programs. Please let us know. You can email feedback@ltccc.org to be included on that. And also, we would love for you to share them because we not only want to reach ombudsmen, we want to get to families, of course, and we want to get to the agencies and legislators. And the reason why we're doing these programs, one, of course, is we want to be able to engage ombudsmen and families, but also to provide perspectives and good data information to our legislators who too often only hear from nursing homes about what's going on. And as a result, far too often, the resident voice is not heard and residents' needs are not met. Uh, Working with us on our data is John Rodat. And actually, I did a program, as I was telling, I think Teresa and Paula earlier, and Haley earlier on, excuse me, for Region 6 yesterday. And one of the people on that program knew John. So that was kind of funny. But John Rodat has a long career in Albany policy and working with data. He's just one of the smartest people I've ever met. And he's been working with us on our data project. So, especially for Teresa and for Region 4, who couldn't be here today, we want to, provide, anything you see that looks interesting, we could certainly provide more of. So feel free to keep that in mind. Also, to keep in mind is that, as I said, I have a lot that I wanted to talk about today. The materials will be posted on our website, and the recording will be posted on our website by Monday. So please feel free to share that, and we'll update the data by Monday, if not before, on the website, the data which I'll be talking about today. So as I said, we're going to provide a data briefing, including some discussion of the rights and requirements regarding safe staffing in nursing homes. And that'll be the major focus of today. And then we're going to spend some time focusing on the rights of families in nursing homes, and by that I mean families and friends, and we'll leave some time for Q&A. So, first, a little background on the requirements for sufficient staffing. So these are federal requirements. They came about as a result of the 1987 Nursing Home Reform Law, which was passed by Congress and signed into law by Ronald Reagan in 1987. I mention that because it's important for us all to know that these laws are not new. The law is not new, and the standards are not new. The standards have been around since the 1987 law was implemented, in 1991. And why do I say that? Because nursing homes have been around for a long time, and they know what they're expected to do. And nursing homes that don't want to follow the requirements that I'm going to talk about are free to operate a private facility that only takes private money. But the fact is that nursing homes, especially for-profit operators, are very attracted to the Medicare and Medicaid dollars that come in because we taxpayers pay for most nursing home care through Medicare and Medicaid. But in order to accept that, nursing homes agree to follow these requirements and to meet or exceed the minimum standards. I know a lot of this can be tough and challenging for families, for residents, for ombudsmen, for those who are working with them. But as I note here in the last blue bullet, knowledge equals power. If we don't know what our rights are, then we can be sure that we're not going to get them in the lives of our residents. But if we know what our rights are, at least we have a basis for advocating and educating. And that includes, as I mentioned before, educating legislators, because I think we've been in a situation in New York, especially for a long period of time, where we have these strong federal requirements, but they're not implemented in the lives of residents. Too many facilities, far too many facilities, operate very short-staffed, and we, too often accept really poor care, sometimes really dangerous and harmful care, as being acceptable, and it's not. I know it's tough. I have a family member myself in a nursing home right now. I know how challenging it can be, but we're trying to think of every single way in which we can connect with families and residents and ombudsmen and legislators to get them on the side of residents as the law requires. I just want to note, as you can see here at the end, that the focus of this discussion is on the federal requirements. Again, these long-standing requirements, they've been around for 40 or so years now, or maybe 30 years. Yeah, 30 or so years now, for nursing home standards, especially in regard to staffing. However, states can have additional standards and protections. For instance, Karen is joining us. Hey, Karen, thanks for joining. For instance, New York has a quantitative minimum staffing requirement of 3.5 nursing staff hours per resident per day. So I'll be talking about the requirements for staffing, and the federal requirements are not quantitative. They're not a number. The federal requirements are in regard to sufficient staffing. And ensuring that residents get the care and services they need, as I'll talk about in a moment. But in addition to that, on top of it, New York has a quantitative minimum staffing requirement of 3.5 nursing staff hours per resident per day. So some of the fundamental requirements for care staff, and again, no need to take notes. I'm going to share at the end. We have a fact sheet just focused on nursing and administrative services that's available on our website. And again, this program will be on our website. Before I get started talking about some of these federal standards, I just want to explain what you see here in purple: nursing services, 42 CFR 483.35 and F725. Why do I include that here? What is that? So 42 CFR, that's the Code of Federal Regulations. You don't need to be a lawyer. You don't need to remember that. but everything that we do, all of our fact sheets that on residents' rights, all include a citation to the federal code. Why? Because I've been doing these programs now for over 20 years, um, as I always say to families or ombudsmen or other, the public stakeholders, is you shouldn't, look back on a program and think, okay, some bull guy came in to our, into our office and said, these are the rights, these are the requirements, blah, blah, blah. All the requirements that we talk about are based upon the code. And if anyone questions them, or if you want more information, you can go back to the code, or they can go back to the code. You can just cite. And all of our fact sheets, except for a few, are 2 pages front and back, so they're easy to print out and take with you to a nursing home or to a meeting with a legislator, et cetera. So that's why we include the 42 CFR there. Again, you don't need to remember that. You don't have to look it up, but it's there in case you need it. The reason why we include the F number, and here it's F725, the F number is what's called an F tag. So for every federal nursing home standard, there's a related F tag. And the F tag is when the surveyors come into a nursing home, and if they find a violation of minimum standards, each standard has an accompanying F tag, and that's essentially how the surveyors code it. We don't get into coding. We don't care about coding. The reason why it's could be important to us as families, as ombudsmen, as agency stakeholders, et cetera, is that when a facility is cited, there is what's called a statement of deficiencies, and that form is usually available at the front desk of nursing homes, or I've seen it at on a coffee table in the waiting room. It's at the front, et cetera. It's on the New York State Department of Health's nursing home website for every nursing home, and it's on the federal Medicare.gov Care Compare website for every nursing home. So when a facility is cited, this paperwork, the statement of the deficiencies can be found in the nursing home, on the state website, and on the federal website for nursing homes. For each citation, the surveyor puts in the F tag. So this is a very long way of saying that the reason why this is potentially important is that if you are going into a facility and you're looking at their most recent statement of deficiencies, or you're looking online, and each deficiency will have noted at the top on the left-hand side the accompanying F tag. And so you can see there what the violation was. And the statements of deficiencies tell a story, essentially, what the surveyor, what the inspector found was the problem, was the violation in that facility. Families, ombudsmen, other resident advocates, et cetera, can use the F tag to see, okay, what is the facility required to do? What are they expected to do? So again, a very long way of saying that F tag is just to keep in the back of your mind. When you see that on a statement of deficiencies, you can come back here to us. We actually have a guide to nursing home oversight, which includes the whole chart of F tags. If you do a search online, Google it or whatever, you can see the F tag list for nursing homes and get the whole list. But that will enable you to see, okay, what was the nursing home supposed to do? And this is incredibly useful, I think, for resident and family councils, because they can see what their facility was supposed to do and track whether or not it is addressing the issues that have been identified. So sufficient staff. The facility must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to all residents in accordance with resident care plans. That includes licensed nurses and nurse aides. As I note here, there are some very limited circumstances in which some of this, in which that can be waived in terms of the licensed nurses 24 hours a day. But here, this really spells out that CMS, the federal government, Centers for Medicare and Medicaid Services, expects that there is going to be sufficient staff 24 hours a day, 7 days a week, 52 weeks out of the year. And I realized as I was talking about this that I talked about what CFR is and what the F number is, but I didn't talk about what this fundamental requirement was, which is, I'll read it. The facility must have sufficient nursing staff with the appropriate competencies and skill sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnosis of the facility's resident population. So I know it's a lot here and a lot to unpack. Again, we have this on our fact sheet, but it's really clear here what the federal government is expecting. I mean, when we think about it, and those of you who have been either in a nursing home or had a family member or loved one in a nursing home, you know that you're entrusting that facility to provide care to someone who's in a very vulnerable place in their life, generally speaking. So the rules really speak to that over and over and over again, that the staff has to have, must, not may, not if there's enough money, not if, if it works out for them. They must have sufficient nursing staff, and those staff have to have the competencies and the skills both to assure resident safety, but also to assure that the residents are receiving the care and the services they need to attain and maintain their highest practicable both physical, emotional, and psychosocial well-being. Um, Really important. It's not okay to have a facility that maybe provides decent clinical care but treats residents poorly and disrespectfully. That's not okay. The CMS over and over again in the rules looks at both psychosocial well-being as well as clinical and physical well-being when it comes to resident care. As I saying before, nursing homes are entrusted with very vulnerable people. They are paid significant amounts of money to do that. But in any case, they have that trust. And these are the bases for the requirements. Are these things happening? And how are they supposed to be happening? Well, they're based upon the residents' assessments and then the individualized plans of care that come from that. And just as a quick aside, we have actually a few fact sheets on resident assessment and care planning. And we also have some tools on resident assessment and care planning, because when I first started doing these programs many, many years ago now, with family members and family councils, they were always very, very interested in the resident assessment and care planning, because that's really where the basis, as CMS is saying here, that's the basis for how care should be provided to each resident. So I want to talk a little bit about nurse aid competency. Again, you see the 42 CFR and the F tag. So the facility must, again, must, not may, not can, not should, must ensure that nurse aides are able to demonstrate competency in skills and techniques necessary to care for residents' needs, again, as identified through the resident assessment and in the plan of care. So here, importantly, two things is that one, in the middle part, this comes from the guidance, the federal guidance. The facility has, people are onboarded, excuse me, when you have a new nurse aide, et cetera. But the facility has 4 months to ensure that that individual who would be functioning under the supervision of more experienced nursing staff in the facility, that in order for that person to continue beyond that period, they have to, within 4 months, have demonstrated competency in all the skills and all of the knowledge necessary to perform their duties. And then the other important point here is at the bottom. So, quite often we know that some facilities, some more than others, and we can show you these data, this information later on, use temporary staff. And those temporary staff too often may not know the residents themselves and their needs. There is no excuse there. And as CMS says, a facility must not use on a temporary, per diem, leased, or any basis other than a permanent employee any individual who does not meet the above requirements. So there's no excuses whatsoever. And again, and I hear this often when we meet with CMS officials on regulations and guidance, is that facilities and their staff are expected to meet the residents where the resident is. This is not just providing services. It's not an auto shop where you come in and you're doing a rote oil change, or you're doing testing the brakes or rotating the tires. This is based upon individuals, and the rules say it over and over and over again. And I'll say, that I know as a family member, I know when I've spoken to family members over the years, sometimes they get upset and frustrated when they hear about this because their residents are not getting this level of service. And I know it's really challenging. So I don't want to dismiss that by any means, but again, trying to provide the information and the and valid data and information on residents' rights to help us support our advocacy for better care. So a little bit more on competency. So this is CMS's statement on competency. I took it from the federal training for surveyors, for the inspectors. A competency is a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics that an individual needs to perform work roles or occupational functions successfully. See, the reason why I include this is because it's really clear over and over again. It's spelled out that CMS is expecting that anyone who has contact with the resident is competent and is focused on the resident and supporting him or her as an individual in achieving the quality the quality of ability, the abilities and the quality of life that they can achieve. There are required performance reviews for nurse aides. Nurse aides have to have a performance review every 12 months, and they must also have regular in-service training. And then here are the requirements for in-service training. In-service training must be sufficient to ensure the continuing competencies of nurse aides, but no less than 12 hours per year. It must include dementia management training and resident abuse prevention training, which I think is so important because these are both issues that we hear about too often. The training must address weaknesses that have been determined in nurse aides' performance reviews and facility assessment, as well as addressing any special needs of residents that have been determined by the facility staff. And then for nurse aides who are providing services to individuals with cognitive impairments, Alzheimer's, etc., also address the care of the cognitively impaired. So important because too often we hear of residents with dementia just not getting the care and services to meet their needs for where they are as individuals. And I just include this slide because I wanted to know, we have a lot of facilities nationwide and in New York and certainly in the Hudson Valley that operate with very low staffing. And too often that is just not cited. So I wanted to note here that surveyors are required to review for insufficient and inadequately trained staff. It's a mandatory facility task when the surveyors are in the building. So I want to dive into the data a little bit, unless there's any questions regarding the requirements. And again, all this is on our website. I'll show you the fact sheet. I thought I had the fact sheet here at the end. I believe I do. In any case, so data. Very quickly, why are data important? Again, they provide evidence of what is going on in specific nursing homes, as well as nursing homes in our community. They enable us to make comparisons between nursing homes. Now we can even make comparisons between nursing home companies. As of 2 years ago, the federal data include the nursing homes that have a corporate owner, and we provide those data in our provider database. And of course, they support efforts to improve care by residents and families, by ombudsmen and other advocates, and hopefully by providers. We encourage providers to use these data too. I actually just was part of a co-author of an article on geared to focus on providers using these data to better evaluate how they're meeting the needs of their residents. And of course, as I've said a number of times, policymakers, is we want to make policymakers aware of the experiences of residences and their constituents, excuse me. So first I wanted to show you, now as I mentioned at the start, New York State has a minimum staffing requirement of 3.5 hours per resident day of nurse staffing. So I looked at the data. These are the most recent data for the first quarter of 2025. Nursing homes are required to report their staffing for both nursing and non-nursing staff, as we'll talk about in a little bit, for every single day of the year, and they do that in quarterly files. So at the end of the quarter, they have given some time to compile their data. They have to be based upon on auditable payroll records, and then those data are submitted to CMS where they're vetted. Every facility that is in compliance with this reporting requirement is there, so that unfortunately is not every single facility. You might find that your facility is missing. It's the vast majority, but if a facility either did not provide good data, or if a facility is a special focus facility, which has been designated as one of the 100 or so worst in the country, then those data are suppressed. But otherwise, the data for every nursing home is here. And so what we did is what we do, I should say, excuse me, with our data files, which we'll explore a little bit more today, is we take that data file, which comes out after a couple of months after the quarter, and we clean it up. We make it more user-friendly. We average out the days. So the CMS, the federal data file, is over 1 million lines of data. It's every single nursing home, 15,000 nursing homes in the country, every single day, Monday, Tuesday, Wednesday, 90 days in the quarter for all these different categories of nursing. So we average it out to show people what their nursing homes and the nursing homes in their communities are providing on average. And here you can see these are all the facilities in the Hudson Valley, excuse me, that are failing to meet on a regular basis the New York State legal requirement of having 3.5 or more hours per resident day of nursing care staff. And sadly, that's more than half of the facilities in our communities are failing to provide that. And you can see, I mean, these are some names that are frankly familiar to me over the history of my work. Northeast Center is one of them. We see a lot of grand facilities. Among them, we see Sapphire facilities, some of the larger companies. Campbell Hall is unfortunately one that I've been familiar with for many, many years. So and there are others here of course as well. But this information is important because we can see here, okay, these are the facilities that are just kind of flouting, frankly, the basic New York standard, which is very modest. 3.5 hours is really not a very good standard at all, but it's something. And even this low standard facilities are too many facilities are flouting. So we've done something really interesting and useful in the past year with our data reporting is we started including with our staffing data and with our provider data, the expected nursing staff. And what that means is that nursing homes, they provide essentially the raw data in those files. And that's what CMS provides to the public. What CMS also started providing, I think it was last fall, is they started providing what's called the case mix index. And I don't want to spend too much time on that, but essentially what that means is that residents are evaluated on a regular basis using something called the minimum data set. And that will tell, or that includes things like, have they lost the ability to go to the bathroom? Have they to walk to the bathroom? Have they become incontinent? Have they received an antipsychotic drug or an anti-anxiety drug? Have they fallen? Have they uh, do they have dementia? There's many components of the MDS. Again, to get a full picture of what is going on with the residents. So this is something. It's an official document that's or list of questions that is used, and based upon the MDS, which shows the needs of the residents in the facilities. Yes, the person has become incontinent, or yes, the person is on a ventilator or is ventilator dependent, etc. Based upon those dozens and dozens of different criteria, the facility has what is called a case mix index, meaning the mix, the needs of the residents in that facility as a whole, and it's assigned a number. And so what we've started doing when CMS started releasing the case mix index and the MDS data last year is that we have incorporated an evidence-based methodology to compute the expected staffing levels based upon that case mix. So some residents have much lower needs. They may need some help with dining or queuing, but they don't need help with other things. Whereas you may have someone who is ventilator dependent. You may have someone who's in pediatric facility who tend to have much higher needs. You may have someone who's there for rehab and have high therapy needs. There's a whole list that compensates out to the different levels of needs. And what researchers have done over the years is they've been able to identify essential. They've researched to see how long does it take to help someone who has a feeding tube? How long does it take to help someone who is on a ventilator? How long does it take to help someone go to the bathroom? How long does it take to help someone who needs certain services? And so they use those numbers. Again, this is evidence-based, and using the case mix index to identify the expected nurse staffing for those residents. So what I have here is, again, just for the Hudson Valley, our counties, as you can see here under the county name, we have the total nurse staffing, which we report on average for the quarter. This is for, again, 2025, the first quarter. And then next to it, the expected total nurse staffing. So here you can see this is the frankly the worst facility in this regard in the region is Renaissance Rehab and Nursing Care Center in Dutchess County. So they provided a total nurse staffing hours per resident day of 1.92, including RNs, LPNs, and CNAs. Their expected nurse staffing, again, based upon what they themselves reported their residents' needs was 5 hours of nurse staffing time. So they had a total deviation of 61.6%. They were the highest. So these are essentially the bottom 20 for the first quarter of this year. So that's total nurse staffing. That includes RNs, LPNs, and CNAs. This next chart shows you the expected registered nurse staffing and the bottom 20, Hudson Valley nursing homes. And you can see here there are really significant deviations from expected staffing with the RNs. Excuse me. The reason for that is because, frankly, RNs are the most expensive of the nurse staffing. They're more expensive than LPNs, and they're much more expensive than certified nurse aides, CNAs. So when facilities try to maximize profits and minimize expenses, they will often cut back as much as they can on nurse staffing. And that's unfortunately what we see here. Well, we'll explore the data in a second. Actually, we'll do that right now. And as you can see, it's not all red. Here we have Elizabeth Seton Children's Center in Westchester is staffing above expected staffing. Helen Hayes in Rockland, their facilities are above. Here, Kendall on Hudson, actually in Westchester, they're about 12% above. But let's explore the data. I'm going to share with you now so this is, and we're going to post this on the website. This is the staffing information. We report this again on a quarterly basis after CMS reports. So as I mentioned before, we clean up the data and make it a little bit more user friendly. We do that on a national chart, but here I've done it and I'll post it just for the Hudson Valley. And you can choose, you can of course search by provider name. But you could also choose county if you wanted to look at a specific county. So let's just look at Dutchess for a second. So these are all the nursing homes in Dutchess County. I'll make this a little bit bigger so we can explore a little bit more easily. And I could pick more than one county if I wanted to. And then from there, this is the MDS census. So that's the average number of residents over the course of the quarter. You can see they're not whole numbers because they're averaged out. Total nurse staffing, HPRD, hours per resident day is here. But as I've been saying, that doesn't tell the whole story. Here's the nursing case mix index. You don't have to worry about that number. But again, just like with the F tags and the Code of Federal Regulation number, we like to provide the public with the information so they know that we're not just making it up. This has all been vetted and is evidence-based. And then here is the expected total nurse staffing for these facilities, and then the deviation. And as you can see, just looking at this, at this column, that it varies in color. So we have dark green, which unfortunately we don't have any green here in Dutchess County, would indicate that they were meeting or exceeding. And then lighter pink is a little bit closer to meeting the HPRD. And then as it gets darker, you see it gets further and further away from meeting the total nursing hours per resident day. And then we also provide to the public information on the total nursing care staff. So because the total nursing staff over here, that includes the RNs who are doing administrative work, and the LPNs who are doing administrative work. The total nursing care staff hours per resident day excludes administrative and director of nursing. And I don't want to get too much into the weeds, but this number is important because actually the New York State law requiring a minimum of 3.5 hours explicitly says hours of staff providing care, which is good. We're really thankful that that was included because it eliminates the administrator, the administrative staff, et cetera. And that's important because, like, as I've said to people in CMS a number of times, no one cares if the administrator has a nursing degree. He or she they're not there on the floor supervising care. They are sitting in an office someplace. So what people really want to know, who's overseeing the care, who's providing the care to my resident, and that's what this number provides. And then we also have, and this is our file again. You can see this on our website, both for the Hudson Valley as well as our national file. If you're looking, if you have a loved one in another state, et cetera, or outside of the Hudson Valley community. This is the total RN staffing. And then again, we have the expected RN staffing and the deviation from the expected RN staffing. And I know this doesn't look good. Again, we're just looking at Dutchess County. I can go back to looking at all of the Hudson. And you see we do have some that are meeting the staffing needs of their residents. But this is really not, unfortunately, not a surprise to me or to others who have looked at these data and done research. Most nursing homes, frankly, are understaffed, and or are clearly understaffed, I would say, based upon federal studies or what kind of staffing is needed. And so that is not in itself a surprise. And then, unfortunately, New York State has always been amongst the lowest staffed on average in the country for nursing homes. We've always, through my entire career, we've always been in the bottom quintile, meaning the bottom 20% in the nation in terms of our overall staffing. And that is particularly bad because nursing home residents in New York tend to have higher needs, higher acuity than they do in other states. And the reason for that is because in New York, we have more opportunities to get care at home, more opportunities than in most other states, more opportunities to get care in assisted living. So people don't wind up in a nursing home until their needs are much higher than, say, Mississippi or Arizona or North Dakota. So that's why and that's why you're seeing so much red, frankly, for New York. Maybe more so. I haven't looked into this yet, but I wouldn't be surprised if it's more so than for other states. So we have also the RN care staff, so not excluding administration and DON, which you can see here. And we have notes and glossary and on this file, so you can see, some of the shorthand what we're talking about. Again, we've tried, I don't want to overwhelm people with information, but we try to provide you with the basis for everything that you can use in case there are questions, in case anything is confusing, to go back and find out what those are, what HBRD means, etc. And then we have the LPN staff, and then we have the nurse aide staff, as well as the total nurse aide staff, the expected nurse aide staff, and the deviation um, from the expected nurse aide staff. We also have here, as reported by CMS, the total contract hours. These are people who are not permanent employees, but contract employees in the facility, and the percent for each facility of total contract hours. And again, you can look and you can see, say we wanted to go to, let's pick a different county. Let's go with Rockland and Putnam counties for those nursing homes. And we can see here the total contract staff, it really varies. Like Putnam Ridge uses 14% total nurse contract staff, which is high. It's significantly higher than the state average, and which is even higher than the national average. Here, 12.5% at Putnam Nursing and Rehab, but others, let's see, Helen Hayes uses 0 contract staff, Northern Manor, Northern Metropolitan and Muncie uses 2.2 contract staff. We saw a lot of contract staff during the COVID pandemic, and then a reduction in that during the post-COVID period. So, and you can easily look up again for your own facility if you're looking at a facility. So here, you just click on provider name and say I wanted to look at Ferncliff. I just go to Ferncliff, and that'll come up right here. So easy to take that information, and you can also, if you wanted to, if you're doing one or more facilities, just copy and paste that into another file, or print it out as a PDF and take it with you. So that is the that's the nursing staff levels. I'm just looking at our time. And then I want to talk a little bit about the non-nursing staff levels. So this has always been an issue of interest to me. When CMS started, or the federal government, I should say, started requiring nursing homes to report their staffing for every day, of the year on a quarterly basis, they required, as you can see, some very specifics about RNs, LPNs, CNAs, what they were doing. Were they administrative or were they providing care? The use of contract staff, etc. CMS also started requiring facilities to report on select categories of non-care staff, non-nursing, excuse me, I shouldn't say that, non-nursing staff, excuse me. And so when CMS started making these data files public in 2017, we at that point started reporting them to the public in these files. And so if you go to our website, you can find the staffing data from 2017 on, and we update them. It takes us a few weeks to vet the data and clean it up, etc. But we update them, and get them out as soon as we can after CMS reports them for both nursing and for non-nursing. And when I review those files before they get published, I've noticed for years that like some of these facilities don't have a lot. I mean, obviously they don't have a lot of nursing staff, which is no surprise to anyone who has been involved in the nursing home world as a consumer or ombudsman advocate, et cetera. But they also too often have a significant absence of important non-nurse staffing. So I want to focus today. And again, if you have questions, feel free to email us feedback at ltccc.org, or if you want more of this in a future program, let me know. Excuse me. But we actually did a study 2 years ago now, looking at the medical director presence in nursing homes. So these are the requirements for medical directors. Excuse me. So, medical director, of course, means a physician who oversees medical care and other designated care and services in the facility. The medical director is responsible for coordinating medical care and helping to implement and evaluate resident care policies that reflect current professional standards of care. The facility has to have a doctor serving as a medical director, and the medical director is responsible for implementation of resident care plans and the coordination of all medical care in the facility. Um, the facility must identify how the medical director will fulfill their responsibilities to effectively implement resident care policies and coordinate medical care for all the residents in the facility. And the facility must ensure that all responsibilities are effectively performed to ensure that residents, again, attain or maintain their highest practicable physical, mental, and psychosocial well-being. So there are really significant requirements for a medical director. Remember, as I think you all know, the only people who are typically on a floor in a nursing home are CNAs, LPNs, and RNs. So that medical director, even, they're not there all day, every day, but they have a really key responsibility to be supervising and to be ensuring that care policies are carried out, and that the care in the facility complies with professional standards of care for residents. So that's why it was very surprising to see that a lot of facilities report no medical director time whatsoever. And we did, as I said, we partnered with academics and did a study on this that was published, and we have a webinar on that study as well. But we found nationwide that about 42% of nursing homes report no medical director time whatsoever. Um, Very, very concerning. In response to that study, CMS actually improved some of the guidance around medical director time. Around medical directors' duties and expectations. But here for the Hudson Valley, these are the nursing homes who in 2025 first quarter reported no medical director time whatsoever. 42 out of 92 nursing homes. Now, nursing homes, some of them argue that, that they, what are the arguments about reporting? It's because it's such a high number, we just have wonder sometimes what is going on with that. I think, the issue is largely that facilities frankly, are not really adequately monitored by medical directors. There are requirements and methodology for reporting when a medical director it comes from an outside service, or when they work, say, for a chain and they're in a facility. They're not working directly for the facility, but they're working for the chain. There are methodologies that facilities have to report that, to ensure that the reporting is accurate, excuse me. So it's really alarming, again, to see how few medical directors there are. And with that, I want to just quickly show you some of the non-nurse staffing here. Again, this is a file. We have the last file for the end of 2024. So we keep these updated as they come in on our Hudson Valley page so that you can see. But here it's the same kind of format as what we saw before, but this is for non-nurse staffing. So here, I'm just going to move this over. Again, we have the MDS census. We have the hours of administrator time, and then the minutes per resident day of administrator time. And the reason why we include the minutes per resident day, and for the nursing time, we included hours per resident day, but the numbers of administrative time per resident, medical director time per resident, et cetera, tend to be much, much, much lower. So we wanted to put it in a format that was somewhat useful for comparison. I hope that makes sense. But you can, and the reason why it's included, excuse me, is because some facilities are very big and some facilities are very small. For instance, here, Glen Arden, if you can see that highlight, has an average of 36 residents per day, whereas Friedwald Center in Rockland has 172 approximately residents per day. So just having 5 hours, they both have close to 5 hours of administrative time, but that makes a really big difference in terms of the amount of time the administrator is actually there effectively overseeing what's going on in the facility. But let's get to medical director. So here's the hours, the raw hours of medical director time, as well as the minutes per resident day of medical director. So you can look up for your facility. You can look up, as I showed before, for a specific county or counties. So let's look at Columbia and Greene. So that's just Columbia and Greene counties to see those facilities and the hours of medical director. You can see they really vary. Look, Pine Haven Home has a medical director on average 10 hours per day, and Ghent Rehab and Green Meadows have 0 hours of medical director time per day. And then we'll move along. So we also include hours of pharmacist. That's really important because it's required that a pharmacist review every resident's medication record at least a monthly basis. So how is that happening if a facility never has a pharmacist in the building? And again, we obviously, have advocated for many years for improved oversight. That's key to what we do. Trying to get the Department of Health to do stronger oversight, trying to get CMS, the federal agency, to do better oversight. I'm not saying for anybody to go in and say, oh, you have 0 pharmacists, so you must not be doing this job. That's not really our goal as advocates. But the point more is that if you're, say, a family counsel or an advocate, an ombudsman, whatever, is to say, okay, you have this information, so that can inform the questions you would ask or the observations that you would make when going into a facility. Are there residents having their medical records evaluated by a pharmacist on a monthly basis? That's very important when it comes to the use of, especially when it comes to the use of psychotropic drugs, antipsychotics, et cetera, which is a problem in many facilities, et cetera. So I know we're running low on time, but we also have here hours dietitian, hours of PA and NP, and these are all explained in the notes and glossary, but we include social work time, activities time, occupational therapist time, PT time, etc. So you have a lot of different information here, which can be useful to all of us, and sometimes especially families who are looking to see, okay, what PT, what PT and OT are available in a facility. Are they really actually providing that? So that's a little snippet of the non-nursing staffing. Again, if you have questions or interested in more, certainly there's a lot on our website, but we'd be happy to, address some of this, in another program. Let me go back to the PowerPoint. And then I want to quickly, I know we only have a few minutes, but talk about some of the resident rights related to, in particular, to families and friends of residents. And when I say families, I mean families and friends. So one, families and friends are just critical supports for individual residents. We hear time and time again from providers themselves that, residents who have a family member there or a friend tend to get much better care and much more attention. And family councils, excuse me, is something that we have long supported. And the more I know about what goes on in facilities and the struggles and the challenges that families face, the more I think that how important a family council can be. One, research has shown that having an active family council improves care for all residents in the facility, not just those who have a family member on the family council. And while the idea of joining a family council can feel burdensome, it can actually be a tremendous relief to the burdens that family members face. Um, why? One, power numbers is that saying one person complaining is one thing. Having a group that is raising an issue, making a complaint, or raising a concern, etc., that can be very, very powerful. Also, a lot of people have fear of retaliation, and working through a family council can help reduce that greatly because you're complaining, or you have a suggestion or recommendation or a concern, and you're iterating that as a group rather than as an individual. And then I think for family members, knowing that you're not alone is really makes a difference, because so much of the burden that I've seen personally as well as professionally is people that are, they're dealing with so much with their family member, and they're dealing with the challenges of the nursing home environment, and they just feel like they can't take on another thing. But actually, if you have the help of others and are not just out there, making the case yourself, and you're able to share with others and hear from them, that it can be tremendously helpful and again, alleviating of the burden. So I know we only have a few minutes left, so I'm going to go pretty fast, but I wanted to know, because I hear a lot from families, and we've done some work with family councils over the past several years, that there can be real challenges just to even being a family council. So here again, from the federal rules, nursing homes are required to protect and promote the rights of each resident, including the right to organize and participate in resident groups, and the family's right to meet in the facility with the families of other residents. And there's really specific requirements around this. The facility has to provide a resident and or a family group with with private space, and take reasonable steps with the approval of the group to make residents and family members aware of upcoming meetings in a timely manner. Staff, visitors, or other guests may attend resident groups or family group meetings only at the respective group's invitation. They cannot, they cannot push themselves into these groups. And what I often see is that with a well-functioning group, it frankly is that they might have a staff member come in for part of a meeting, but then leave, so that there's private time for the residents and or the families to talk. The facility has to provide a designated staff person who is approved by the resident or family group and the facility, and who's responsible for providing assistance and responding to written requests that result from the group meetings. Again, this is not me making it up. Comes from the federal rules and the federal guidance. And this I thought is just so important, because it's too often, what we hear about from families not happening. But the facility must consider the views of a resident or family group and act promptly upon the grievances and recommendations of such groups concerning issues of resident care and life in the facility. The facility must be able to demonstrate their response and the rationale for such response. This doesn't mean that the facility has to implement any requests or recommendations from the resident or family group. So essentially, what this means is that facilities have to respond to concerns raised by family councils and resident councils. They don't have to do, just because a resident council or family council asks for it, that doesn't mean they have to do it. But if they're not going to do what the resident family council wants, they have to demonstrate their response and the rationale for their response. Just can't be, oh, we can't do that. or we're not going to do that. That's not our policy. That's not good enough. There has to be a rationale for it. So these are our fact sheets on resident and family council. As I said, we have dozens of fact sheets on our website, all are free to use and to share. We also have some additional resources at Nursing Home 411. This is, excuse me, our family council empowerment resources. It includes free meeting rooms if you want to include a private Zoom room for your family council. And we have resources like fact sheets, as I mentioned before, tips for compassion fatigue, privacy and independence, participating in a nursing home staffing assessment, etc. And we have also some tools for resident-centered advocacy. So we have record-keeping tools like when there's a problem, but we also have family council and resident council meeting notices that can be easily used and filled in by the resident or the family council so that, just to make it easy for them, we have a sample agenda that they can use. Again, print out. We have it as a Word file and as a PDF file, whatever's easiest for people to use. They're more than welcome to. As I mentioned, we have our dedicated Hudson Valley page. We have a guide for legislators, which we encourage you, if you are a legislator who's attending this program, or if you're working with the legislators, to share with them. And then we have a dedicated page, LTC in New York, as well as our Hudson Valley page. And then we have two dementia care toolkits. One of them is new, for people in assisted living and home care, and the other one we've had for many years for people in nursing homes. Our next program will be December 11th at 11 a.m. We're going to provide another data update. If there's anything particularly you're interested in, again, please email feedback@ltccc.org. And then the resident rights focus will be on what to do when there's poor care, abuse, or neglect. Making a complaint or registering a concern and how to do that. We thank the Dyson Foundation and Field Hall Foundation for supporting these programs. I know we went over, but I'm happy to stay on if there are any questions. Oh, okay. Well, very good. Thank you. Yep,
Can
sorry.
I'm sorry,
Of
can I
course.
just ask a question?
Yeah.
I have a question about residents' rights in participating in family council. I just recently formed a family council. We're in the Capital District, not in the Hudson Valley region. And we're just in the process of developing our bylaws. One of the things that I was unclear about was residents' rights in participating in family council in addition to resident council. Let me just pull this up for a second. The federal regulations state the resident has a right to participate in family groups. Does this mean that we should be including residents in every family council meeting? Should they have voting rights? I was just unclear, what does that mean, participate in family groups?
That's a really interesting question. So, to be honest, I wasn't that supportive of this rule because we support both resident councils and family councils, but sometimes I think some separation can be useful when uh, because there can be different priorities.
Mm-hmm.
So, uh, essentially, how I interpret this is that a family council can't exclude a resident. So residents are welcome, but you don't have to actively invite residents to your resident council. Um, and I think in terms of voting, that's a very good question. I mean, I would think that, frankly, I would tend to think that if you're there, you can vote.
Mm-hmm.
Um, but I would, it may require some thought. And, as I said, as I've been saying, I know sometimes it could be burdensome to have a family council, but I really do think it pays off both emotionally and in terms of improvement. So I hate to add a potential burden, but I think I
Mm-hmm.
would Probably proceed carefully. I would, if you, so if I would allow everyone to vote is how I would personally do it. Again, I think it's kind of open, but I would also, if you run into issues, I would consult with your ombudsman and ask for
Okay.
their help, because one of the reason why I was not really that supportive of this change in the rules, which I think was like 2000, I want to say 2016 or 17 or so, is that I've done a lot of work with family councils over the years, and I know when a resident is there, sometimes it could be really good, but sometimes they can be, frankly, disruptive. And um, so I would hate for that to get in the way of the family council.
Yeah, I just to share a little bit. So I fully want to involve residents as much as possible. I think there's a lot of residents at our facility who don't have family members to represent them or just not
Mm,
actively representing them. Currently in our bylaw, I did actually reach out to our ombudsman and I did get some conflicting information on this. She had said to me that it's entirely up to the family council to
mm,
decide if residents will be voting members. And right now we have the membership defined as family members, friends of residents, or representatives of residents. Um, but I just wanted to make sure that we weren't doing anything in conflict with the federal regulations. And it just clearly states in the regulations that residents have, a right to participate in family groups.
right.
Um,
So I mean, I would go with that.
mhm,
Again, I just wanted to be careful. Um,
mhm,
I um, I would just see how that fun. I mean, if someone objects, then they may have, my way of thinking. The reason why I said have allow them to is that I would lean towards allowing them to vote is because if the resident objects, then that can put the family council in a difficult position that you don't want to be in.
mhm,
So again, my feeling is I prefer that they, frankly, that they were, that there was that separation, but um, um, when there's not, and participating doesn't include voting, as I would understand it.
mhm, mhm.
Um, but you can try that, and if there's an objection, then you might need to change that. But my thinking is
Okay.
being as conservative as possible in terms of interpreting the rules, and also trying to avoid any possible issues down the line. You won't
Mhm,
have a possible issue with the resident if you do allow them to vote, but if you don't allow them to vote, if you exclude them, that could result in a potential issue. In my
mhm. Yeah. Okay. Thank you so much.
Sure, yeah, no, thank you. It's a really, really interesting and thoughtful question.
Thank you.
Thanks. Thank you, everybody. Appreciate you joining, and hope to see you soon. Bye bye now.